Good evening, everyone. My name is Corinne Bush, and I am the Executive Vice President of the Board for Certification of Nutrition Specialists. The BCNS is proud to partner with the American Nutrition Association, the ANA, and AMG Naturally in this Nutrition Pro educational webinar. The American Nutrition Association is very pleased to be hosting Dr. Datis Kharrazian tonight to discuss thyroid health. Let me take just a moment to tell our audience about the ANA. We are a nonprofit organization which for over 40 years has been on a mission to promote optimal health through nutrition and wellness education. We educate the public and professionals in many ways, including hosting world-class nutrition programs, such as this one tonight. We encourage all of you listening this evening to visit our website at theana.org for an abundance of nutrition information, resources, and upcoming webinars. Join the ANA as a member and help us continue to bring these nutrition luminaries to you. The ANA would like to thank AMG Naturally for their support of this educational webinar. Learn more about their medical-grade botanical anti-aging skincare products at amgnaturally.com. And now we are honored to introduce Dr. Datis Kharrazian. Dr. Kharrazian serves as an associate clinical professor for the Department of Preventive Medicine at Loma Linda University School of Medicine, and is an adjunct professor at the National University of Health Sciences and Bastyr University. He is considered one of the leading experts in non-pharmaceutical applications to chronic illnesses, autoimmune disorders, and complex neurological disorders. Patients from all over the world fly to his practice located in San Diego, California, to learn and understand his perspective regarding their conditions and to apply natural medicine alternatives to help them improve quality of life. His first book, Why Do I Still Have Thyroid Symptoms When My Lab Tests Are Normal? A Revolutionary Breakthrough in Understanding Hashimoto's Disease and Hypothyroidism, quickly became a bestseller. Welcome, Dr. Kharrazian.
Kharrazian, I'm going to speak to you about some of the research and some of the findings we've had with thyroid. So one of the things that I want to go over will be some of the outdated concepts we have with thyroid, things like goitergenic foods, things like iodine usage for everyone, things like axillary temperature. Those really are really outdated concepts. And I also want to show you some of the research with newer findings, concerns with things like iodine, autoimmunity, oral tolerance. I'm going to show you some research with molecular mimicry associated with the thyroid and things like that. So this being a supplemental conference, what are the best supplements for the thyroid health? What are the best ones? Is it iodine? Is it tyrosine? Is it a special extract? Is it selenium? What are the best things? So in order to really answer what the best supplements are for the thyroid, you really want to ask the question first, what's the mechanism? Why do people have hypothyroidism? Is hypothyroidism caused by a nutrient deficiency? Do you guys think hypothyroidism is caused by nutrient deficiency? Is there someone who's low in a nutrient, then they become hypothyroid, and then they take it and everything's cured? Or have you guys ever seen that happen? Let's say it's iodine, for example. Has someone really been low in iodine, that causes them to be hypothyroid? They take iodine and their TSH goes back to normal, their hair grows back beautifully, their skin all of a sudden looks great, their metabolism's back to normal, they don't have any of those issues anymore, their energy's exploding because a single nutrient helped their thyroid. No, we don't see that. So the whole model of trying to find a single isolated nutrient deficiency to treat the thyroid is really an outdated model. And kind of when we look at things, when we look at chronic diseases and we look at how they fit in, when we use the world of nutrition, and nutrition, that's kind of the basic training model. You find a nutrient deficiency, you find what they're low in, and then you try to support them. I don't know about you, but in my practice, and I'm sure just like yours, most patients that come in that are chronic are coming in with bags and bags full of supplements. They're taking more nutrients than you could ever imagine. You guys know what I mean? They come in and sometimes you may say, list your supplements, and they give you a sheet, and you go, oh my gosh. And then they go, turn it over. You're like, turn it over? And they turn it over. You're like, oh my gosh. And they go, there's some I haven't put on there. You're like, wow, you're taking a lot of stuff. So if it was really related to just a single nutrient deficiency, or maybe even if it was malabsorption, other things like that, then we would be able to address those things quickly and be able to make a difference for hypothyroid people, but we're not. And hypothyroidism is the most common condition. It's out throughout the world. And in the top 10 medications, there's always usually in the top 5 is levothyroxine. So it's one of the conditions you'll see most often in patients, especially in women. So what is the mechanism? What causes hypothyroidism? So we know it's not a single nutrient deficiency. We know people all of a sudden don't become thyroid because they're low in a nutrient, including iodine. The mechanism for most hypothyroidism is an autoimmune attack. It's Hashimoto's. That's the mechanism. So will a single nutrient reverse an autoimmune attack? Will a single nutrient cure an autoimmune disease? Is there a cure for an autoimmune disease? No. It's an uncurable condition. It can maybe be put into remission, but it's not going to be cured, right? So when we have people looking for the best supplements or the best nutrients to give to the thyroid, it's a failing model. It's a failing model. So the number one cause of hypothyroidism is Hashimoto's. And how do you identify it? You identify it with TPO. If TPO or thyroglobulin are elevated, then the person has Hashimoto's. Now, most people get diagnosed with hypothyroidism, but they don't get diagnosed with Hashimoto's. Why? How would you confirm it's actually Hashimoto's? You would run the antibodies. And do insurance companies pay for the antibodies? No, they usually don't, because they go, what's the point? It's not going to change treatment. Why would we run TPO and thyroglobulin, which cost between $200 to $400 each, to confirm that they have diagnosis that it's 90% probable? Now, the model for thyroid disease is you get diagnosed hypothyroid, your TSH is high, so doctors will usually confirm the diagnosis with high TSH, right? Hypothyroid. Tell the patient, hey, you're hypothyroid. What's the cause? I don't know, genetic. Did your mom have it? Yeah, your mom had it. Yeah, it's probably just one of those genetic things. You know, they happen. We don't really know why, but they just happen. And you have this hypothyroid metabolic endocrine disease, but in fact, they really have an immunological autoimmune disease, right? It's one of the most common autoimmune diseases to show up. And current statistics by the American Autoimmune Disease Related Association are showing that 1 in 12 women now have autoimmune disease in the United States, 1 in 12. And the most common first sign of an autoimmune disease for most of them is hypothyroidism. So we have many people that really walk around thinking they have hypothyroidism because their doctors never ran the antibodies, primarily because it's not routine to run them, doesn't change treatment. And that standard protocol is to come back every year to get what? TSH measured. Why? Because it's expected the thyroid gland will be destroyed. It's a progressive, ongoing autoimmune disease. It's expected that the thyroid gland will be destroyed every year more. So they'll have to adjust for that by giving more thyroid replacement. The whole model of coming in every year and getting your thyroid levels measured and then seeing if you need to take more is based on the fact that it's for the pathophysiology of a progressive, ongoing Hashimoto's disease. So most people that are diagnosed hypothyroid have no idea that they have hypothyroidism. Does that make sense? Okay. So when someone has an autoimmune thyroid disease, they're in an inflammatory cascade. So what does the inflammatory cascade do? Because the inflammatory cascade causes a whole list of diverse symptoms. We're going to go over some of them. But one of the most phenomenal things that the inflammatory cascade does is it actually impairs thyroid proteomic post-transcriptional receptor site expressions. So the more inflamed someone is, the less responsive they are to thyroid hormones. So they can take the thyroid hormones and have their TSH look normal because of a negative feedback loop, but at the receptor site, there's very little expression impacting their metabolic response, right? That's what chronic inflammatory cytokine levels do to thyroid receptors, which is part of the pathophysiology of Hashimoto's. So the first thing is, I think it's really, really important if you guys are looking at thyroid patients, take the next step if you haven't already been doing it. Check their antibodies and confirm that the fact they have autoimmunity. Because if they have autoimmunity, it's a whole different world. You guys understand? So now you're going, okay, I'm going to figure out what nutrient and lifestyle dietary interventions to use, not because there's a gland defect, but because the immune system is actually attacking the thyroid. Okay? The more specific your protocol interventions are to the pathophysiology or the mechanism of the condition, the more successful you will be. So when you look at the typical Hashimoto's, there's some kind of environmental trigger, breakdown of immune tolerance, T and B cells activate, they get into the thyroid gland to destroy the thyroid gland, and that's the whole thyroiditis thing. So, most of us have learned hyperthyroid as autoimmune as always being hyperthyroid, right? Graves or Hashimoto's thyroiditis. Most hypothyroidism is Hashimoto's hypothyroidism. So there's a slow, progressive, inflammatory attack against the thyroid gland for many years to many decades, and then eventually they lose enough follicular cells, and then their TSH has to compensate, and they increase TSH levels, right? So we know there's genotypic susceptibility. We know some similarities between HLA-DQ2 and 8 genotypes associated with celiac and some co-expressions there. And then diet, lifestyle, and environmental factors change phenotypic expressions. The immune system slowly starts to attack the thyroid gland over several years, loss of thyroid tissue, leading to decreased thyroid production, elevation of TSH. They finally get diagnosed hypothyroid. TSH is managed by replacement, but no management for immune response unless hyperactive, right? So you have an autoimmune disease. We're going to put you on this replacement. We're going to completely ignore the pathophysiology and the mechanism of your autoimmune disease. And we'll just try to compensate by giving you this replacement, hoping it's going to fix the other parts of it. And then that's why these patients have continued symptoms, and they still have hair loss and have weight loss issues and have even some weight gain issues with those that are too thin, ongoing intestinal permeability, more and more food sensitivities. They get into chemical reactivity. They get to other co-autoimmunities, and they have this ongoing progression. And they think, man, I'm this weird thyroid patient. No one can figure it out. But they're not. They're an autoimmune patient, and no one's letting that be known, and they're not being diagnosed properly, and no one's actually hitting the autoimmune component of it. So that's the problem that we faced. So these are some of these papers. Hypothyroidism can be induced by various diseases. An autoimmune cause accounts for approximately 90% of adult hypothyroidism due to Hashimoto's disease. 90%. The majority of Hashimoto's patients are women aged between 20 and 60 years old, and nearly 10% show overt hypothyroidism. With time, euthyroid patients progress to hypothyroidism. So what this shows is this, and this is what investigators have found out. Most people will have antibodies for the thyroid, and with all autoimmune diseases, there's what they call a silent stage first. You show the loss of self-tolerance, you make antibodies, but you have no symptoms. And over time, as the immune response progresses and you have more T-cell destruction of the tissue, you start to develop symptoms. But when people have Hashimoto's, they still have enough integrity of their follicular cells, so their TSH is normal, and they're fine. So, but they'll have thyroid symptoms all the way through. Do you guys understand that? Like, let me show you this. Let me go back to this first lab. What's this person's TSH? Normal, even within functional standards. But they have autoimmunity. So this is a person who isn't in the hypothyroid state yet. This is Hashimoto's expression, but it's not Hashimoto's hypothyroidism yet. So there's many people that have all these thyroid symptoms, and they just have the autoimmunity there. So if you guys see patients coming in, they have all the symptoms of thyroid, you probably should check their thyroid antibodies, because there's an immune attack against those cells, right? And those cells become less efficient, and they may not keep up with their metabolic needs. So here's another interesting paper. Thyroid autoimmune disease are the most frequent autoimmune diseases in the population, being present in average of 7 to 8% of the general population. Now this is full hypothyroidism, Hashimoto's, 7 to 8%. How many people do you think would be accounted for if they actually measure those that are in the second stage, silent stage, or the reactive stage? Probably more than 7 to 8%, right? And this study is a little bit flawed because it checked men and women as a general population, but we know that this occurs primarily in women, so if they check primarily in women, it'd probably be over 10%. And if they were looking at autoimmune reactivities, it'd probably be even higher than that, just instead of just frank hypothyroid end stage. Does that make sense? So chances are, if you're seeing women come into your office, at least 10% of them may have some degree of thyroid autoimmunity going on, and those are the ones you want to catch, and you want to treat them from an autoimmune model instead of trying to treat them from a thyroid nutrient deficiency model and then blame it on iodine and think that you need this perfect type of replacement to fix everything, and that's where people fail with a lot of these thyroid patients, okay? So what will thyroid replacement do to the autoimmunity itself? It has very little effects. So when you look at the research, thyroid hormones initially, for the first few weeks, have been shown to dampen inflammation. So what do patients feel when they first go on thyroid hormones? They feel good. And then that's what we call the honeymoon phase. And then what happens like month 2, month 3? I don't feel good. So they've lost that inflammatory suppression. And then what does doctor do? You may need more. You may need more. You may need T3. You may need bioidentical. And maybe they do, because maybe they have some degree of thyroid resistance from the inflammation. But maybe they don't. Maybe they take it and now they can't sleep at night and have palpitations, they have anxiety. And then they go, I don't know why you're not responding. You're so weird. That's what we see, right? You guys all see the same thing. Okay. So, this is the same thing. More of the research showing that it's really Hashimoto's is the main mechanism. This study found that it was 75.5% of hypothyroid patients really had Hashimoto's. The other one was 90%. So chances are the majority of people you see that are actually hypothyroid really have an autoimmune mechanism. So what are the symptoms of someone who has autoimmune thyroid? or Hashimoto's. And remember, they don't have to be completely end-stage hypothyroid yet. They could be in the autoimmune reactivity stage, just have antibodies, not have high TSH. So you're going to see they're going to see symptoms of hyper, which would be what? It'll be off and on. It'll be palpitations, inward trembling, nervousness, anxiety, right? And then hypo, sluggishness, constipation, fatigue, right? Poor hair growth, poor nail growth, hair falling out, all those things, and then go back and forth. They'll take thyroid meds. They usually go through that honeymoon phase, and then they go, hey, I just don't really feel any better. What symptoms do you have? If you listen to their symptoms, they're all hypothyroid. They still have, many of them, as any fact, the TSH keeps going up. If their TSH keeps going up, what does that tell you about the rate of their autoimmunity? So here's an example. Someone has hypothyroidism, they went on medication, replacement, the TSH went down, but within 3 months, their TSH went up again. And then 2 months later, their TSH went up again. And 2 months later, their TSH went up again. Versus someone who's been on the same dose for 3 years. Which one is progressing faster? The first one. The first one is having more and more loss. So when you see your histories and go, hey, how often have you had to increase your dose? And they say, well, frequently. Then you know their autoimmune disease is more rapid. Does that make sense? It's more aggressive. So those things are important for us to know as clinicians. So I wrote this book, Why Do I Have Thyroid Symptoms? I wrote it in 2009. And one of the things, I wrote this book, and I didn't think anyone would read it, but it became a bestseller. And since then, we've had, I don't know, over 100,000 people on our online web pages giving us feedback, and we have people on our newsletter, and we're getting feedback from thyroid patients at a high level every single day. And then I teach this course to healthcare practitioners, and other people teach it for me at 200 locations. So we teach about 10 to 15,000 practitioners this topic for the past 10 years. We have a lot of feedback from practitioners and patients of what's working and what's not working. So what do we know? We know we have a complete disconnect with thyroidism and natural medicine. People are still measuring axillary temperature. Guys, what does axillary temperature tell you about the thyroid? It's so non-specific, because anemia, anything neurological that impacts thermoregulation, other hormone imbalances can impact your axillary temperature, okay? So we have those things. And then you have the goitergenic foods we'll talk about, completely ridiculous. Okay? And then everyone's searching for iodine. And the cutting edge people in natural medicine or in medicine are going, I use Armor. I'm awesome. Or I use Armor and Thyroid together. I'm cutting edge. And you're like, it's autoimmune. What are you doing for that? Well, what do you mean? So this is the area of frustration we have. Now, here's what we do know that's very interesting. 52% of patients with thyroid autoimmune disease can be considered affected by autoimmune polyneuropathic syndromes. More than half of them have antibodies to other tissues, other autoimmunities. Okay? And I would say that number is more, at least in my observation, but this is what's published in the study. Okay? So when they come in and tell you they have hypothyroid, as a clinician, you should first find out if they have an autoimmune condition going on. And the second question is, where's the rest of it? Okay? So this is a panel that we do, and we check for the most common autoimmune target sites for our thyroid patients. This is a test that's available commercially, and we check for parietal cell intrinsic factor, ASCA-ANCA for intestinal autoimmunity, smooth muscle autoimmunity. We know they have thyroid autoimmunity, adrenal, cardiac, phospholipid, reproductive, joint, bone, liver, type pancreatic, and then neurological. You know what the most common thing we've seen over the years, just from our small group, has been? That's actually a pretty large group now. Neurological autoimmunity. Most thyroid patients have cerebellar or GAD65 antibodies. Many even have myelin antibodies. And the next one is islet cell antibodies. That's what we see. Now, what's been published? What's been published, one paper found that hypothyroid patients, between 12 to 14% of them have intrinsic factor antibodies. So they end up with, omegablastic anemia from it. One study showed 5% of those tested had GAD antibodies. GAD antibodies are the earlier marker for type 1 diabetes and also for neurological related symptoms. GAD is the enzyme glutamic acid decarboxylase, GAD65. It's used in the pancreas for neuroendocrine effects of insulin release. But GAD65 was also used for GABAergic pathways, mostly involving basic ganglionic loops, direct and indirect. When people have those, they get things like OCD and hypokinetic movements and things of that nature. So we see a lot of other neuroautoimmunities. So what I always try to do, when I see it work with a person who comes in my office and I see they're diagnosed hypothyroid, I go, have you had antibodies done? If they haven't, we want to check. And then we check. And then, hey, do you have any other autoimmunities? And a lot of times from their history, you can see they have other neuroautoimmunities or other types of autoimmunities. Okay? Now, A lot of them also have adrenal antibodies, but they don't have addisons. Do you know how much tissue loss you have to lose to start failing 24-hour urinary markers to be diagnosed with addisons? You have to lose 90% of your adrenal gland integrity. So you have all these people that are chronically hypoglycemic with low thyroid, but they have positive adrenal antibodies. They still make levels of reproductive hormones for the, not reproductive, but adrenal cortex hormones for their adrenal hormones, but they're not in the addison stage yet, right? So we see all types of subtle little things like that. So we know that these people have autoimmunity. So what's the common thing? What is the common history of a thyroid patient? And we get so many of these through our online, web pages and newsletters when people respond back. And here's what they usually say. It's usually very long. Oh my God, thank you. Finally, I figured out my diagnosis. That's how they usually start. Because most of them take forever to get diagnosed, right? A lot of them have a hard time first being diagnosed hypothyroid, and then the next battle is to actually get diagnosed that they have an autoimmune disease. So you hear this whole story of all the doctors they've seen, all the crazy things they've been told, all the different medications they've been on, all the crazy natural supplements they've tried, and then finally they go, oh, someone actually figured out I have this autoimmunity, and that really starts to make sense for me. Now I'm trying to do an autoimmune lifestyle, and blah, blah, blah. So what you'll see is you'll see one person here's an example. One person gets diagnosed in their history, and they go, thank goodness, now I'm on levothyroxine, and they initially feel better, and they're so hopeful that finally someone diagnosed them, and they're going to take this magic thyroid replacement, everything's going to go away, and they're going to be back like they were in the college years, and rainbows come out, and all this stuff. And then they sadly find out that doesn't work, so they go on their search to get more answers, and then where they usually end up? They usually end up with someone that does bioidentical. The next step, the cutting edge step, right? And then they may get, some armor or some other variant. And then they have a little honeymoon phase and think that's the answer, and then they're sadly let down. And then they're frustrated, and they have multiple conditions, and no one knows what's going on. They get very intimidated to actually tell doctors their history anymore because they think they're crazy. And they start doubting themselves, and they go into states of depression, and their whole sense of self and soul and everything gets destroyed, and they don't know what to do. They start reacting to foods, they start having systemic inflammation, they get multiple symptoms, now they start developing multiple autoimmunities, they have no idea that's happening, and they go and see someone and goes, I think you need this really cool iodine, or I think you need this one nutrient, and it doesn't work. That's the average history we hear. That's what we hear on a daily basis from people, right? I'm sure you guys do in your offices as well. So what are the best supplements for thyroid health? Let's go back. I don't know. Well, let's talk about iodine, because everyone brings that up. You guys, let me put it to you this way. Iodine is contraindicated in Hashimoto's. And I'll show you guys the research. Please give me a sec. And go on PubMed yourself and look it up. There's more papers than I have time to show you. Yes? So let me get to that variable a little bit later with pregnancy and other issues. But just in general, iodine itself for the topic of autoimmune thyroid. Okay? Yes, we know iodine has impacts on fibrocystic breast. Iodine is a key nutrient. And then someone else said, well, isn't the U.S. population deficient of iodine? Yes, the U.S. population is deficient of every nutrient. Which one are they not deficient of? Tell me which one. Is everyone cool with zinc? Everyone has plenty of zinc? Everyone has plenty of molybdenum? That's just not a good argument, okay? Now, you guys, I'm not saying that there isn't a need for iodine. That's not my argument. My argument is that iodine has been shown and published as a trigger for an autoimmune thyroid patient. That's an absolute fact. It's at the point now that if you gave a Hashimoto's patient iodine and they went into thyroiditis, and an attorney did a literature review, they would find plenty of evidence that that could be contraindicated. That's where it's at. So I just want to show you the information. How you use that information clinically with your own patients is your thing. I just want to show you one side of what's out there that no one seems to know about, okay? So let's talk about iodine first. So iodine administration was accompanied by an increased titer of thyroid autoantibodies and increased prevalence of hyper and hypothyroidism. This was published in 2003, okay? School children. New England Journal of Medicine, 2006. This is a study they did in China. They had It's a 5-year study, 1999 to 2004. They examine the effects of differences. They go in regions of China where they know that they have iodine deficiency. They evaluate about 3,000 subjects, and they measure their thyroid hormones. They measure the thyroid antibodies. They measure their iodine in the urine, and they do ultrasounds of the thyroid. Pretty good workup. And they monitor them for a 5-year period. What did they find? More than adequate or excessive iodine intake may lead to hypothyroidism and autoimmune thyroiditis. They found they gave people iodine, they got rid of their iodine deficiency, the lab markers look better, but they see a spike and a shift and a correlation with iodine intake. Okay? Another study was done in 2003. Going into regions, once again, iodine deficient. To study the evolution of thyroid autoimmunity in relation to change in goiter prevalence during 3 years of iodine prophylaxis in Sri Lanka. These results indicate an evolution of thyroid autoimmune markers during the course of iodine prophylaxis. So they see when they go in there and give people iodine, and yes, those that are deficient, if they have Hashimoto's, their thyroid reaction flares up. What's the target site for autoimmunity for Hashimoto's? It's TPO and thyroglobulin antibodies. TPO and thyroglobulin, right? What does iodine do? Iodine increases the production of TPO and thyroglobulin. It's a trap. I mean, iodine trap, you take it in, you increase levels. Here's another study published in Thyroid, 2006. In conclusion, they did the same thing. They took about 1,700 adolescents in areas where they were iodine deficient. They looked at their free thyroxine, TSH, TPO, antithyroglobulin, urinary iodine, thyroid ultrasound. In conclusion, iodine supplementation in Turkey has resulted in elimination of iodine deficiency in the eastern Black Sea region. Great. That's what you would expect. And this has been accompanied by an increase in the prevalence of autoimmune thyroiditis and thyroid dysfunction. Are doses reported in those studies? Yes, they are. Now, this is a similar study they did in Greece, 7 years. They found the same thing. This is another one they did. This is a correlation, experimental effects of iodine deficiency, excess of thyroid autoimmunity. And then look at this. Iodine may exert influence on the level of CD4 and CD8. That's your immune response, right? Helper suppressor ratios. And thus the production of thyroid antibodies might directly or indirectly take part in process of thyroid autoimmunity. Both low iodine and 100 times normal iodine intake, here's your range, might activate the immune state on some degree. The effect of iodine immune response of TGO and TPO antigen and thyroid autoimmunity might not be completely the same. One can flare up more than the other, but there's a flare-up. There's an immune response. There is a T-cell response when Hashimoto's patients, a susceptible subtype, take it. So this was another study, found similar things. And if you guys go to PubMed, you see many of these studies. This was a study I did with risk factors for postpartum thyroiditis. We conclude that positive TPO antibody was the value for predicting the occurrence and severity of postpartum thyroiditis, and high iodine intake was a risk factor triggering postpartum thyroiditis. Okay? Here's this paper published in Thyroid, 2004. And it goes into why measure thyroglobulin autoantibodies rather than thyroid products antibodies, and here's one of the things they found. It's conceivable that thyroglobulin polymorphisms, one of the susceptibilities for Hashimoto's, combined with explosive mix of iodine, TPO antibody, hydrogen peroxide, the inflammatory response, necessary for thyroid hormone synthesis, inadvertently provides a trigger for autoimmune thyroid responses. Okay? Here's more. This is a study, European Journal of Endocrinology. So this goes on, and that's what we see. So and let me explain something. If you guys have not been in touch with patients, go on thyroid forums. The largest Facebook forum is Hashimoto's 411, which actually was started from my book. There's over 50,000 people on that Facebook page. And listen and read their reactions when they take iodine. Some of them completely fall apart. Now, is it every case? No. But as a clinician, you need to know it's a risk factor. For some susceptible people, it could be an issue, even if they're deficient. And whether it's low iodine or 100 times normal iodine, these have been studied. So these researchers did this study. Look at the title. The effect of iodine restriction on thyroid function in patients with hypothyroidism due to Hashimoto's thyroiditis. Well, that's a cool area of research. So instead of giving them, let's restrict it in their diet. Does that make any difference? Okay? So this study investigated the effect of iodine restriction on the thyroid function and the predictable factors for recovery in patients with hyperthyroidism due to Hashimoto's thyroiditis. Subjects were divided randomly into 2 groups. One group was an iodine intake restriction group, iodine intake less than 100 micrograms per day. And the other group was an iodine intake non-restriction group. They were allowed to eat as they were. So they were getting more than 100 micrograms per day. So they checked thyroid-related hormones, urinary excretion of iodine were measured at the baseline and after 3 months. In conclusion, 78.3% of patients with hypothyroidism due to Hashimoto's thyroiditis regain a euthyroid state in iodine restriction alone. How many papers do you need to see? And if you need to see more, could you consider the fact that you may have a bias because you've always associated iodine with thyroid? If you go to a group of practitioners and say, what's the first nutrient you think when I say thyroid? What do you think people are going to say? Iodine. It's textbook. I've done that in seminars before. First thing that pops in your mind, nutrient, when I say thyroid, iodine. We're so classically trained to think iodine is what you give all of these thyroid patients in a nutritional model, in a deficiency model. Now, so that's the story with Hashimoto's people. So you got to be careful of that. You got to consider that possibility. I will tell you without doubt, you will see many Hashimoto's patients. You look at their list of all the stuff they're taking. You restrict iodine. You just do that for the first few days. Many of them dramatically feel better. Okay? Now I want you to think of another scenario. Let's say someone comes in with Hashimoto's and they have antibodies to myelin basic protein also. And they have antibodies to islet cells also. And their HbA1c is borderline diabetic. And they're starting to develop symptoms that look like MS, but MRIs are normal. Okay? So if they have no autoimmunity against their pancreatic sites, but they're not diabetic yet, borderline, and they have MS-like symptoms, MRIs are normal. So they're having autoimmune reactions, but they're hypothyroid. Antibodies are off the chart for those markers, and you give them iodine. What autoimmune response do you think you have potential to trigger? All of them. Because if it activates the T-cell response, you can see that happen. And you'll see people that have a whole list of new symptoms when they do it. Okay? And the most common thing you'll see is many people go into hypersymptoms. They take iodine and they have anxiety and they can't sleep and they get nervous because they're becoming a little hyper when they take it. You guys understand? What happens when here's a scenario. Someone has high TSH, they take iodine, their TSH goes down, and they now tell you they have anxiety and can't sleep well. Did the iodine work? Well, if the iodine can trigger the autoimmune response, what happens when you have non-response against the thyroid gland? You destroy tissue. What's in the tissue? Hormones. What does the hormones release do to TSH? It brings it back down. Now they're having anxiety and nervousness because there's too much thyroid hormones in their bloodstream. Does that make sense? So there's also a period of time when many Hashimoto's patients have TSH is normal, TSH is low, TSH is high, TSH is all over the place because their autoimmune response is flaring up and down. It's going through relapse remission process before all the follicular cells are destroyed to the degree that TSH is high all the time. So sometimes they look normal, sometimes they look low, sometimes they look high, they're going all over the place because of that. So when they get an immunological flare-up and they break down tissue, the tissue breakdown releases hormones in their bloodstream and that brings the TSH down. Does that make sense? Okay, so let me tell you, before I move on, let me just say this. I really don't want to fight anyone about iodine. I just want to present this side of it to you. I want you guys to know you should look at forums of actual thyroid patients. You should go to Medline, read some of the research, and if all you leave it with is the clinical consciousness that it can be a trigger for some subset of people, most commonly Hashimoto's hypothyroid, then that's great. Does that make sense? There's individual uniquenesses, individual factors, case by case, but it seems to be something that you should know about. Now, what if someone has a goiter? Is iodine appropriate for someone who has a goiter? I don't know. That's why I made a slide, I don't know. So the first question, what's the mechanism of goiter? What causes goiter? Can iodine deficiency cause goiter? Yes. But what's the most common cause of goiter? Hashimoto's. So let's talk about iodine causing goiters first. How does iodine deficiency cause goiter? Does the thyrocytes all of a sudden don't have iodine and they swell up? Is that the mechanism? No. You guys, the mechanism for developing goiter is chronically high TSH exposed to thyroid cells. That causes a hypertrophy of the thyroid cells. Okay? Now, most common reason for someone to have enlargement of their thyroid gland that's diffuse, not solitary, like a nodule, is actually Hashimoto's. A painless thyroiditis. And how do you tell them clinically apart? How do you tell a goiter apart from a painless thyroiditis in a clinical setting? The difference is Hashimoto's thyroiditis swelling comes and goes. Goiters don't change size. Yes, goiters don't change size. They're tissue that's hypertrophied. The only way they'll shrink is if you put them on replacement and you atrophy it. They're not going to come and go in size. So someone says, hey, I have an enlargement of my thyroid gland, and you ask it, hey, does it come and go? Are there days where you have difference in your voice? There's different days you can swallow? And they go, yeah, I've noticed that it does happen. It gets worse when I'm under stress, or it gets worse when I eat certain foods. Those are suggestive to you that that's more likely a thyroiditis swelling. Does that make sense? And if you do ultrasound, you rarely won't see anything abnormal. If it's true goiter, ultrasound, you'll see the enlargements. Okay? Now, so here's the thing too, it's very interesting. In areas of iodine insufficiency, TPO antibodies associated with endemic goiter. And despite long-standing iodine supplementation, the prevalence of goiter remains high in some areas. The study suggests that autoimmunity may be one of the mechanisms responsible for goiter, persistence after iodine supplementation. So here's the thing. This patient walks into your office. First question, is this a goiter or is this diffuse enlargement from painless thyroiditis from Hashimoto's? How would they feel to you, first of all, if you palpate? One's going to feel really cartilaginous and thicker than the others. Is going to feel more smushy, first of all. Then the next question is, you want to ask, does it change size for you? Does it come and go for you? If they say yes, you're immediately starting to think what? More of a thyroiditis. Now, if it's actually enlarged and it doesn't come and go, and it's been growing, you suspect the fact that it could actually be a goiter. Okay? Now, if it is an actual goiter, you can do an ultrasound, you can confirm it, they can get the size of it, measure it, and see if it grows over time, right? But let's say you have an actual goiter. If you have an actual goiter, if it was iodine, here's a question. If the mechanism was still going on causing goiter development, what should you see on labs? How should the TSH look? TSH should be high, because it's the thyroid stimulating. You guys, two things are going to cause goiter: high HCG, high TSH, as far as endocrine hormones. Okay? And then you have goitergenic mechanisms we'll talk about in a second. But high TSH is going to cause that hypertrophy to cause goiter cell enlargement. So if they have a goiter and there's a mechanism still causing it, you would see high TSH. Okay? So what if their TSH is normal and you repeat it and repeat it, it's normal? Then the mechanism that caused it is no longer there. Okay? Now, the most common cause published is Hashimoto's. In many of these studies where they go into iodine deficiency regions and goiter regions of the world, they give them iodine levels normalize, but they get worse from an autoimmune response if they have an underlying autoimmunity. Okay? Now, will iodine supplementation change the size of the goiter? It's truly iodine deficient. Here's what happens. They have high TSH, they have a goiter. You give them iodine, TSH goes down, and they feel better. Will the goiter size actually change? No. Whatever you build and grow, it's there. I mean, you can give enough replacement to cause atrophy, but it's there. So the fact it's changing size, it's very diagnostic. Okay. What about goitergenic foods? Is it real? You guys really think do thyroid patients eat goitergenic foods and then end up with a goiter? Okay, so here's this. What would happen if we went on a goitergenic diet? Let's all go on a goitergenic diet. Let's all eat broccoli, kale, cauliflower every day, collard greens, Brussels sprouts, spinach, flaxseed, pears, peaches, cabbage. Let's only select from the goitergenic food list for the next month. Do you think we would get goiters? No, because this is in vitro testing stuff that's infiltrated the world of natural medicine, and people make this big assumption that it actually makes a clinical difference. Now, chemical goitergens and things like lithium and other types of drugs for sure can have an effect. There's no doubt about medications and environmental factors doing it, okay? But food compounds that in vitro testing show that they can have some goitergenic effects in a real clinical setting don't. As a matter of fact, most autoimmune patients start to feel better when they start to eat foods like this. Okay? So again, if you guys doubt the goitergenic model, go on the goitergenic diet. Get the goitergenic food list and eat it every day and see what happens to you. Give it to your thyroid patient. See if all of a sudden their TSH gets off the charts. This is outdated, just like axillary temperature. Just like iodine for everyone. And all thyroids are iodine deficient. Because we have a US population that's deficient of thyroid. This is the problem we have. We have people saying stuff like this. Hypothyroid rates are increasing. Iodine deficiency rates are increasing. So obviously, it's related. That's like saying there are fire alarms wherever there's a fire that went off. Fire alarms must cause fires. It's this inappropriate association, understanding of correlation, right? Okay. Or association. All right. Now, what about gluten? Guys, if you're worried about a food protein, throw away. If you have goitergenic list foods, throw it away. Pull out your gluten-free list. There's no question that gluten is a trigger for Hashimoto's patients. And many of them share the same susceptible genotype, HLA-DQ2, HLA-DQ8. They either have one of those, and they become very sensitive to it. So this was a study they did, 100 patients, Journal of Clinical Gastroenterology, and they put these people on a gluten-free diet, and here's what they found. The serological markers became undetectable 6 months after beginning a gluten-free diet. However, thyroid antibodies not positively correlate with dietary habits. So their labs improved to some great degree, even though their antibodies didn't go down. In this study, in 2001, American Journal of Gastroenterology, they looked at 241 consecutive untreated patients and 212 controls. They put them on a gluten-free diet, and here's what they found. In distinct cases, gluten withdrawal may single-handedly reverse the abnormality. It's like the progression of the condition stopped. That's why don't play around with this goitergenic list. Play with the gluten-free list, right? This is what patients really need to know when they come in with hypothyroidism. Here's another paper that was published, Hormone Research. On a gluten-free diet, an excellent clinical and histological response was recorded with improvements of hypothyroidism and reduction of thyroxine dosage. Our data suggests that significant high prevalence of gluten intolerance in patients with autoimmune thyroid disorders, in particular Hashimoto's thyroiditis. And then, again, more and more papers showing that there's associations. This was a Dutch study, here's another study that was shown associating with celiac. Here's with tissue transglutaminase. There's paper after paper on gluten and thyroid as a risk factor. Some of these papers say, if you diagnose a person with hypothyroidism, and especially Hashimoto's, you should be screening for celiac disease and gluten sensitivity. Okay? It's a high correlation between these two diseases. And in some cases, it dramatically reverses it. And you'll hear this if you guys go on these forums and actually listen to thyroid patients. It's a problem with the world of nutrition. People have all these theories, they circulate around like Bigfoot theories and blah, blah, blah. And no one can actually find the paper that started it all and ignited it. But it keeps getting passed around like it's actually truth. And people disconnect with actual patients going through the condition and the research. And when you see the research and then you go on forums and you actually hear patients tell their stories and so forth, you will see a high amount of them dramatically change their health when they actually adopted a gluten-free diet. And it's 100% gluten-free diet. It's not mostly gluten-free, right? That's the key thing. Okay. Now, here's the interesting thing. Gluten can cross-react with many different tissues. And I'm going to share some research we did. But gluten, since it's gluten antibodies, can cross-react with cerebellar tissue. Why is cerebellar tissue important? It's one of the most common markers we've been seeing as a group with people that have Hashimoto's. And look at this paper. Anti-TPO antibodies from patients with Hashimoto's encephalopathy bind to cerebellar astrocytes. They're actually finding that antibodies, TPO antibodies, have affinity to bind to cerebellar proteins. What happens when antibody binds to tissue? Well, if it's in the brain, then glial cells destroy it. Okay? So the most common thing is gluten ataxia. So let's talk about gluten cross-reactivity, and this TPO seems to have some cross-reactivity with the thyroid too. So when you have an amino acid sequence, you guys see this? E, Q, V, P, L, V, Q, that's one part of the amino acid sequence of gliadin, and here's cerebellar tissue, E, V, P, L. You guys see that amino acid sequence, right? When there's similarity like this, then antibodies produced against gliadin have potential to bind on the same target sites as the other antigen, like cerebellar, right? This is, for example, myelin and strep. Have you guys heard of PANDAS? pediatric autoimmune neuropsychiatric disorder where they get strep infection and they get all these neurological deficits. That's because strep antibodies can attach to myelin and cause diverse neurological symptoms, okay? So this is called gluten ataxia. Now, if you guys are seeing hypothyroid patients, you should be checking them for ataxia, right? So first do Romberg, see if they sway, and then have them walk heel-toe and see if they're falling all over the place. And then the key test is you have them close their eyes and see if they can take at least 3 steps with their eyes closed. And if they can't take at least 3 steps with their eyes closed, you have ataxia. Okay, without question, they have ataxia. Now, that if you see that the ataxia is of unknown origin, like there's no traumatic brain injury, there's no known neurological disease, that's called idiopathic. And if it comes and goes, that's classified as idiopathic sporadic ataxia. Okay, idiopathic sporadic ataxia. They close their eyes, they fall all over the place, they don't have good balance, there's no known cause for it, and then it comes, it's different. They have the diagnosis of idiopathic sporadic ataxia as their ataxia type. So papers are showing that 60% of those people have gluten as their cause. They have gluten ataxia. One paper was published, it showed 60%. Other papers show 40%, 50%, but the highest one was 60%. But close to half, or more than half, you're in that barrier. Let's just say a large majority of them have it. So you guys, you should be looking at this in your thyroid patients. Just the fact that there's some early papers showing that TPO antibodies can bind to the cerebellum. Now, if they're gluten sensitive and they eat gluten, and gluten has potential for cross-reactivity, now you have potential for gluten ataxia and cerebellar dysfunction, then you can see some problems. Does that make sense to you? So you could have someone, you know what the number one reason is that we see hypothyroid patients not recover or not feel well, where they still come in depressed and they're still fatigued and they still have digestion issues? Because they have significant brain degeneration. So when their brain's degenerated, they can't think, they can't focus, they can't concentrate, their endurance goes down, they're exhausted all the time, and then they have cerebellar ataxia, and they have dizziness. This becomes a huge issue, okay? The motility gets compromised, all these things start to happen because of some of these consequences. So this is how it looks when you guys do dot plot testing. I don't know if you guys have ever seen these, but this is doing dot plot. So what they do with dot plot is you see different wells, and let me kind of explain this diagram to you. So in these wells here and here, that's gliadin peptide. That's purified gliadin peptide. This is crude peptide, so the protein has been purified, okay? These two wells have cerebellar protein on the wells. These wells have MBP, myelin basic protein. These wells have egg protein. These wells have soy. So in this sample here, they mix blood, serum, that has cerebellar antibodies in high levels. And if you mix cerebellar antibodies with cerebellar protein, what should happen from an antigen-antibody reaction? They should react. So you guys are seeing reaction there. That's normal. That actually becomes the control. That's what should happen. Cerebellar protein, antibodies. But look at gliadin. You see that reaction? That's cross-reactivity. That's how it looks here. This is one way to do it with dot blot. Here it is here with egg. So you guys, a lot of Hashimoto's patients have gluten ataxia, also very sensitive to egg protein. And if they make egg antibodies, that could be a potential concern. Okay? And this is, yes, quick question?
So why didn't the antibodies react to the cerebellar protein?
They do a little bit if you see it.
Looks like a very little.
Yeah, but again, there shouldn't be any at all. Right? The way you normally do it in a more efficient test is you do it through optical densities. And with optical densities, you get a very clear measurement. So this is, a dot blot is considered like a quick, because with the lysis when you do with monoclonal antibodies, it's very, very expensive. So the way you first screen with it is you do dot blot. But dot blot's more visible. But the more accurate way to do it very specifically is optical density measurements with the lysis. Okay. Now, here's, hang on with questions. Let me continue if you don't mind the question at the end. So if you guys look at the cerebellar areas here, this is one of these cases. It's really amazing. A brain MRI of a patient with gluten ataxia showing rapid onset of cerebellar atrophy over a 15-month period before the diagnosis of gluten ataxia. So you see some demyelination here in the vermal areas, in the lateral hemisphere, and then in 15 months, just their exposure to gluten caused progressive, serious progression, which was then stopped once they went on a gluten-free diet. So these reactions can be really, really scary. That's the paper I already showed you. Now, what about this for a Hashimoto's patient? What if they ate this? There's no gluten here. Some tuna, some salad here, some vinaigrette, some macadamia nuts, some kale. Could this be a problem? Maybe. So and what about this? Salad, gluten-free, everything's good. What is she wearing? Latex? Would that be a problem? So I want to share you, we've been doing some research with cross-reactivity. Now, we published this paper. This is a paper we published just this past few months, Detection of Antibodies Against Human and Plant Aquaporins in Patients with MS. And I want to share with you some research we're doing with thyroid cross-reactivity. So if you look at the target site for optic neuritis, it's a protein called aquaporin, okay? Aquaporin target sites, aquaporin proteins look like this, but look at soy protein. You see the similarity? You see the similarity with corn? See the similarity with spinach and tomato? Those are potential cross-reactive sites. So in our study, we shown people that had aquaporin receptors. We checked aquaporin antibody proteins for foods. We found very, very, very high correlation. P-values less than 0.001, very high R factor values. Very high correlation. So this could be a potential mechanism for cross-reactivity. Now, what we did recently this year is we wanted to see if there's any cross-reactivity for thyroid patients, for thyroid autoimmunity. So we looked at the following things. We looked at molecular mimicry mechanisms by using purified protein to 220 foods, and monoclonal antibodies. So we had an immunological laboratory make its monoclonal antibodies for TSH, TSH receptor, T4, T3, thyroglobulin, 5-deiodinase, thyroxine, and tridothyronine. And you guys understand what a monoclonal antibody is? Monoclonal antibody, to make it very simply put, it's an antibody that is so specific to binding only to that pure protein. Okay? So they inject proteins in animals, they find the antibody being produced, it's very specific to it, they replicate those antibodies that are not polyclonal from multiple sources, but from one source. Those antibodies, you can only bind to that protein or something exactly like it. So then we took 220 foods and we purified them. So we put these food proteins through dialysis and removed contaminants, so all we had was pure protein. That's how you do cross-reactive research. Okay? So we were doing this in the lab. By the way, this is the molecular amino acid sequence for TPO. So then we take each of those target sites, we figure out which strain of amino acids are the immunological target site. We then send those target lists to a lab. They make us monoclonal antibodies for those, which takes some time. Then we take those, mix them with our purified foods. These are the foods we took. We pretty much took vegetables, grains, dairy, fruit, meats, and so forth. And we looked for potential cross-reactivity. And by the way, monoclonal antibodies, I don't know if you guys seen them, but like a little vial, let's say half size my thumb, it could be $10,000, $20,000. You don't want to spill. Okay. So the way you do the study is you put the pure protein on the lysa plate, you incubate it, so you have that on the well. Then you mix the monoclonal antibody with it, and if there's any cross-reactivity, when you have monoclonal antibody and pure protein, purified protein, if they interact, it strongly suggests molecular mimicry. And then we add a dye, and then the dye changes colors, and then you see these things turn out. Okay? So we just submitted that paper. I can't show you all the data, but I just want to show you a couple things. A couple things that we found was latex was very reactive against thyroglobulin. So remember that picture of the lady working out with latex gloves? What if those latex haven proteins from the latex gloves get in their food? There could be a potential trigger there.
There's hardly any latex in food preparation. They use vinyl.
Yeah, they use latex haven. Latex haven is the protein they have. And then macadamia nuts showed up is one thing. Here's interesting, tuna. Aren't you supposed to eat tuna? Raw. This is like autoimmune. I put these because these are the autoimmune paleo type things, right? Like you think that if you avoid the autoimmune, if you're on an autoimmune diet where you're avoid of wheat, dairy, soy, and eggs, and have vegetables and all those things, to be okay. So we found about, I don't know what the exact number was, but it was between 20 and 30 food proteins that have some target site cross-reactivity. Now, these only matter if the person makes antibodies for them. So in order to have cross-reactivity even be a concern, so you have to have the following things. You have to have an autoimmune response against that tissue. So you have TPO or thyroglobulin antibodies. Then you have to have the actual food antibody elevated. Because if just because you eat it doesn't mean you have a reaction to it. So if you eat it and have very high levels of antibodies, those antibodies can then bind to target sites, and theoretically that could be a potential problem. So we don't know for sure, but these become suspicious foods, potentially, if we see they have very high antibodies to foods that have potential for molecular mimicry. Just like if someone has ataxia, you would go, maybe you shouldn't be eating gluten, or we should check you for gluten sensitivity. Does that make sense? Okay. So I think what we'll see with, and by the way, we did this with chemicals bound to albumin. We found certain chemicals that are very reactive against thyroid target sites, and that's also in submission right now. So here's the thing. One of the things that we're finding is with thyroid patients, we have to look at it from an autoimmune perspective. We have to look at it for triggers. And we know that things like gluten are a big issue. Things like iodine could be an issue for some people. There's potential foods that we think are healthy but may not be if they're sensitive to those foods, that they may cause some cross-reactivity. So the spectrum isn't necessarily looking for an individual nutrient. It's trying to find mechanisms to change the expression of their autoimmunity. Does that make sense? It's kind of a different mindset. You're not trying to find the single nutrient, you're just trying to find mechanisms of try. Now, are there supplements that could also be a concern for Hashimoto's? So here's what I've learned myself as a practitioner. I have become much better at not making patients worse. That's my greatest achievement the past 10 years. I'm not saying I make them better, I'm just saying I don't make them as worse as often. So one of the things that I'm looking for is I'm looking for triggers. The minute they walk in my door, I'm looking, for example, if they have Hashimoto's, are they on a gluten-free diet? Are they taking supplements that have gluten in them? Right? So modified starch, if you see on supplements as fillers, are usually gluten. Okay? And there's publications that have been published, some by Vijnani, where they show gluten can also have cross-reactivity with milk proteins because of structural similarity. And gluten can have cross-reactivity with other grains, including corn and rice. So we're looking for those types of exposures, and we eventually check them for those antibodies. But if they have a supplement and they're taking rice protein and rice is very high, antibodies are very high, we're concerned. We may not want them on those things. If they're taking a medication and they have corn as the major filler for them, we're concerned about that. Because if they have corn antibodies, and corn has been shown to be cross-reactive to gluten because of structural similarity, we try to avoid those. So we're trying to avoid those things as best we can. I tend to not like to have my Hashimoto's patients on iodine. You do whatever works for you, but I prefer not to. We see improvements with them. Now, they have an autoimmune disease. Can their botanicals and herbs they're taking make them worse? So what's happening to autoimmune disease? They have a dysregulated immune system, right? And autoimmune diseases are sometimes classified as a Th1 or Th2 dominant at times, right? It's not the whole model, but it's one of it. We know there's other players like Th3 and Th17 and Th21 and Th22 and Th9 and Th15 for different parts of the autoimmune pathway. Okay, but let's just make it simple. We know there's Th1, Th2 shifts, and some people have dominance there. Hashimoto's people, some papers say majority of them are Th1 dominant and small set are Th2, and Graves is just the opposite. Majority of Graves patients are Th2 dominant, and they measure these by looking at the cytokine dominance from Th1, Th2. So the way they look at these, the way you do this is you can measure levels, but the best way is you take a T cell, and then you expose it with something like pokeweed mitogen, and you see which cytokines are released, and that's how you know which way they're primed. That's how they do it in most of these research studies. So can botanicals stimulate the Th1 side? Yes. Can botanicals stimulate the Th2 side? Could that promote their autoimmunity? Could that potentially make them worse? Yes. So here's just a general list I'm just going to give you. Like things like astragalus, echinacea, glycyrrhiza, maitake, List officinalis. These things have Th1 stimulating activity, right? They have a very powerful effect. And if you're trying to fight an infection, that's awesome. If you have autoimmunity and that's the side of your dominant tissue attack, that could be a problem. And some of these other things for Th2. So one of the things I always like to ask my thyroid patients is, have you ever taken anything that's made you worse? I just want to know. And if I say, oh yeah, I took this mushroom kind of thing, was supposed to be good for the immune system, and I totally fell apart. I'd be like, okay, What about echinacea? Yeah, you know what? I don't think I like that either. Then you start going, maybe I don't want to give them any TH1 kind of stimulating compounds. Maybe that's a bad idea, right? Or it's the strangest thing, when I take grapeseed extract, I feel worse. And so typically things that are on the antioxidant, flavonoid, anti-inflammatory side tend to have more of a Th2 effect. Another major one is coffee. The flavonoids in coffee, which are so protective for neurodegenerative disease and other things. You have patients that have thyroid disease and tell you, if I have my cup of coffee, I'm okay. I feel so much better. They're immunologically. My swelling goes down. My pain goes down. My inflammation goes down. I'm not talking about energy. So if someone drinks coffee and immunological clinical patterns improve, you're thinking that there's probably a positive effect. So in my practice, I'd go, I'm going to load you up on resveratrol, I'm going to load you up on acai, I'm going to load you on these other types of things and see what happens to your autoimmunity, versus they come in and go, if I have one sip of coffee, I have palpitations and nervousness and anxiety for days and days. My joints swell like crazy. My brain's on fire. It feels like I can't even think. My body aches. And those are all immunological. It's not a metabolic issue with caffeine, right? It's not a clearance issue. So those could be immunological. So I want to look for those and see if I can identify them. Here's another key thing. Intrinsic factor antibodies show up in about 12 to 14% according to one study. What do they put in B12 supplements? Intrinsic factor. So that could potentially be a trigger if they have intrinsic factor autoimmunity. So here's a patient, they come into your office, they're taking tons of pills. They're taking iodine, they have Hashimoto's, antibodies, let's say, through the roof. They're taking iodine, they're taking a whole spectrum of botanicals, different immune-stimulating botanicals, okay? They're taking B12 with intrinsic factor. They're taking a thyroid med, and the filler's corn and gluten, levothyroxine, by the way. And they're gluten sensitive, and they're corn sensitive, and that's how they are. What do you think? Well, those are triggering events. So the first thing we do in a supplemental model for thyroid is we look for what to take out. That's our first approach to a hypothyroid patient. What is potentially flaring you up, and let's remove it. Because if you guys see these thyroid patients in your office, being an alternative healthcare practitioner, they're coming in usually taking lots of supplements, right? Out of desperation, they're trying to take the next thing to feel better, and feel better, and they feel better, but they end up with a list of things that can potentially be stimulating. Okay? All right, so those are key things. So what's the best approach for hypothyroidism? Well, here's our goal, here's our model. We want to improve their immunity. We want to improve their tolerance. That's what we're after. We want to see if they can improve their tolerance. By tolerance, I mean tolerance to foods, tolerance to chemicals, tolerance to their self. So the immunological concept of tolerance is you don't react abnormally to a trigger, to antigens. So if you react against yourself and make autoantibodies, that means you've lost your self-tolerance. If you react to chemicals, you've lost your chemical tolerance, right? Your chemical sensitivities. If you lose your tolerance to foods, dietary proteins, then you lost your oral tolerance or dietary protein tolerance. So what we try to do in a clinical setting, first thing with these Hashimoto's patients, is totally ignore the thyroid for to some degree, and really focus our efforts in trying to improve their immunological tolerance. Because if we can calm down the inflammatory cascade against the thyroid, then we have some benefits. So let me put some things into context. When someone has an autoimmune flare-up, what happens? Whether it's Th1 dominant or Th2, right? We have an inflammatory cascade of cytokines. Mostly IL-6, Th17, potentially TNF-alpha if it's Th1, but these inflammatory cascades go up. So you get a cytokine inflammatory storm. The cytokine inflammatory storm is going to cause a systemic inflammatory response throughout the body. Inflammation in the brain is going to decrease nerve conductance. They'll get depression. They'll get slower conductivity. They'll complain of brain fog, right? Cytokine inflammatory responses in their gut actually break down tight junctions. Do you guys understand that? Autoimmunity itself, when flared up, destroys the tight junctions. It's not just that you have leaky gut and you get autoimmunity. The inflammatory response has potential to break down intestinal tight junctions. So they get autoimmune, they get stressed, their autoimmune disease flares up. They just induce leaky gut. Inflammatory cascades can break down the blood-brain barrier. Inflammatory cascades can dysregulate Treg cells. And inflammatory cascades can decrease thyroid receptor site expression, even though there's hormones binding to it. So we clinically see is a lot of these Hashimoto's thyroid patients don't really feel better until we can calm down their inflammatory autoimmune cascade. So that's what our goal is with them. That's what our dietary nutritional supplements and interventions are. We're trying to focus on that part of it. So we try to improve tolerance. So tolerance, whether you're looking, tolerance in general could be central or peripheral. Central tolerance is basically the negative positive selection through the thymus gland, which we're not so concerned with. But I want to talk to you guys more about peripheral tolerance and how dietary proteins and foods impact this. So what you see in this diagram is when people eat foods, right? Because we know that foods can be a big factor in autoimmune diseases, and we know that the initial parts of tolerance are dependent upon breaking down proteins and then having dendritic cells sample them, and then dendritic cells then get into mesenteric lymph nodes and peripheral lymph nodes, and through the portal vein, they can trigger inflammatory responses throughout the body. I'll break this down one by one, but let's talk about where we first start. We first start with protein breakdown. Are they breaking down their protein? So here's what I want you to understand. Digestive enzymes don't only help you digest foods. Digestive enzymes break down amino acid sequences so they become less reactive. Let me say it in a different way. People don't have reactions to foods. People have reactions to amino acid sequences in foods. Do you understand? It's not like the antibody binds to the entire food polypeptide protein. The antibody binds to an amino acid sequence chain. Okay? That's how it works, and that's how cross-reactivity works. They have the same amino acid sequence chain. So if you take a look at this diagram, what you'll see here is you have a peptide, and A, Y, S, R, V, G, T, H. You guys all see that? Okay. On the left is a normal response, and on the right is a lack of digestive enzymes. So if someone has a healthy digestive response, they can break down this into smaller peptides and eventually to amino acids, and that doesn't cause an immune triggering event. But if you had, let's say, this as a target site for antibodies, and this is still hanging around, then you have more potential for immune reactivity. So again, digestive enzymes aren't there just to break down food, they're there to break down peptide sequences, which decreases the vulnerability for ongoing immune reactivity. Now, if you can't break down the peptide sequence, and worse, you have intestinal permeability, and these peptide sequences get through and they get sampled by dendritic cells, you're going to cause a significant inflammatory reaction. So one of the first things we do from a tolerance perspective is go, are you digesting your food? Are you digesting your protein? So what are the clinical symptoms if they're not digesting the protein? Well, for protein, they first of all have an intolerance to it. They're like, I don't want to eat protein. I feel like I have a brick in my stomach. I'll feel heavy all day. That's a major sign of inability to break down protein, right? Bad breath, halitosis, that's another one. Burning, as they get protein putrefaction from not being able to burn it down, reflux. So if they get bloating and distension after protein meals and they feel like it's really heavy and they can't break it down, that could clinically suggest to you that they may need to take some digestive enzymes. Hydrochloric acid, peptidases, right? Those types of things to break down these amino acid sequences. Does that make sense? So one of the first things we do with our patients from an immunological perspective is give them enzymes, not for absorption necessarily, but just to make sure that their immune proteins, their food proteins don't react, okay? Now, this is known, this is published. Look at this title, look at the conclusion of this paper. It is apparent from the study that the potent allergenicity of peanut, soybean, mustard, egg, and milk allergens may be due at least in part to resistance to proteolysis in the stomach. If you don't break down the protein, you get greater allergenicity because they react against an amino acid sequence. And if that amino acid sequence sticks around, you have greater potential for reactivity if you're sensitive to it. Here's another paper. Gastric digestion substantially decreases the potential of food proteins to bind IgE, which increases the threshold dose of allergens required to elicit symptoms in patients with food allergy. You have to break down the peptides to make it less allergenic. So when you see these people that are sensitive to multiple foods and they have autoimmunity, you got to make sure they're having enough digestive enzymes. Now, a mistake a lot of people make is they don't take enough. So they should take enough where they don't have any bloating, they don't have any distension, and they don't feel heavy after they eat. That dose will be different from each person. Okay? Now, the other key thing that some research is showing is food coloring totally sabotages protein breakdown and immune reactivity. So food coloring binds to proteins. Okay? You ever just lick the lollipop and your tongue turns a different color? That food dye is attaching to your tongue epithelium protein. Okay? When food coloring is added to foods, it attaches to that protein. So what happens is, this is a paper that was published called Immune Reactivity to Food Coloring. Digestive enzymes normally break down this sequence. And why is that important if you have overactive immune response to foods? Because once you break them down, you lose the target sites for antibodies to bind to them. But with food coloring, they inhibit the digestion. Okay? And take a look at this. They did the study where they looked at albumin, and the top part is albumin without food coloring, and the bottom one is albumin with food coloring attached to it. Same exact protein, one has food coloring, one doesn't. And they looked at digestion over 60 minutes. So when you see this is with albumin without any food coloring, within 60 minutes you get really good digestion. But when they add food coloring, it's not digesting. And if it's not digesting, what's sticking around? The amino acid target site for antibodies. So here's an example. Someone's gluten sensitive. So when they eat gluten protein, they react to the amino acid sequence chain of gliadin peptide somewhere, and then they have food coloring added to it. So let's say someone has jelly beans, gluten red colored jelly beans, and they have gluten sensitivity. Well, they could have only one jelly bean, only one. But they can't break it down, and this gluten peptide is still there, and it's still having immune reactions, and the amino acid sequence is still hanging out. That can still create ongoing problems. So this is why it's so critical when people have autoimmunity and multiple food reactions that you try to make sure that they don't have foods with food coloring take digestive enzymes. Does that make sense to everybody? Okay. Yeah, these are with synthetic. But I think any food coloring, anything that changes the color by binding to a protein, the color changes, it potentially can impact digestion, I would guess. Now, one of the key things that we need to improve tolerance in our gut are what are called Treg cells, right? So when you guys look at the research on tolerance, the greater your tolerance, the less likely you are to have autoimmune disease and react to things abnormally, right? So the key thing that improves tolerance is regulatory T cells. And regulatory T cells, by the way, we know are impacted by opioids. So if you laugh, if you have healthy emotional opioid responses, if you work out, you exercise, you have your opioid responses, you technically have greater Treg potential function, right? And have you guys seen like autoimmune patients that may come in? Some are coming in with their spouse, they're holding their hand, they have support, they have love in their family. They tend to do better than patient coming in all alone. Their spouse doesn't believe in any of the things they're doing. They come in and say, I hate these supplements. I hate you. I hate the carpet. I hate your shirt. You know, maybe they need a little opioid response. Maybe they need some things to activate those responses chemically, right? A neuroimmune endocrine response. A psychogenic response, right? Those things can be helpful. Now, from a dietary perspective, fibers turn on Treg cells. So things like starch, pectin, fructan get metabolized by gut microbiota to fatty acid metabolites, acetate, butyrate, propionate. And acetate, butyrate, and propionate have the ability to activate and increase the function of Treg cells. So we have our patients try to take fiber. And one of the easiest things they do, it's very inexpensive. Just get a teaspoon of like flaxseed and psyllium, maybe some chia seeds, mix it with water or almond milk, just drink that in the morning. You're getting a huge potential Treg support. You can also supplement with short-chain fatty acids as an attempt to try to activate Treg cells. So for a lot of our autoimmune patients with multiple food sensitivities, we try to give them that. Now, this is a problem for those that have progression into small intestinal bacterial overgrowth. So it doesn't, because you can't give them fibers. So when people have ongoing autoimmunity, and most thyroid Hashimoto's people have ongoing inflammatory reaction in their gut, many of them have celiac disease subtypes or celiac disease itself or gluten sensitivity, the inflammatory reactions in the gut eventually degenerate the enteric nervous system. They actually get neurodegeneration in the gut from the chronic inflammation. They lose their migrating motor complexes, and they end up with small intestinal bacterial overgrowth. So as the inflammation degenerates their gut, they lose their motility, they lose the ability to control their valve, so the valve between their small and large intestine, the ileocecal valve, becomes less efficient. Bacteria translocates from the large intestine to the small intestine, so that's called small intestinal bacterial overgrowth, and then they can't take fiber. And then they can't take fiber, and now they have multiple food reactions. They can't turn on their Treg cells from the main component they need. So we try to give them short-chain fatty acids as a supplement. They can tolerate those. So you can give them butyric acid, propionate, they're usually in calcium forms, to help improve their Treg functions. Does that make sense? Okay. So those are key. And then vitamin A has been shown to be a key factor in dendritic cells. Vitamin D has been a key factor for dendritic cells. So we'll try to use vitamin A and vitamin D. Now, here's an interesting thing for our autoimmune patients and Hashimoto's patients. We know these are the factors we want to try to improve tolerance with. So let me talk about this one here for a second, gut microbiome diversity. The more diverse the gut microbiome is, the greater tolerance you have. So the dangerous thing to do with autoimmune patients is go, you can't eat this, and you can't eat that, and you can't eat this. You can't eat gluten, you can't eat dairy, you can't eat soy, you can't eat egg. And what else do you like? You can't eat those either. So then they're left with, like, what can I eat? Well, I only like 4 vegetables, and they eat the same salad, they eat the same things, and as they do that, what happens to their gut microbiome? The diversity immediately changes, right? So changes take place within 3 days, and then now they have a less diverse gut microbiome, and they've just lost their tolerance to some degree. So one of the things that we're learning is when we're working with people that have autoimmune diseases like Hashimoto's patients is go, listen, obviously don't eat the foods you react to, but the foods like you don't react to, like vegetables, and these are plant-based foods, try to have a more diverse plant-based diet. So do you eat celery? No. Do you have any reaction with celery? No. We'll eat celery. Do you eat parsley? No. Do you care if you eat it? No. Well, eat it. And then you go through the list and you try to make them as diverse as possible. And then an easy way to do it is for a lot of these patients is have them get like a Vitamix or those blenders, like a Ninja blender you see now at the commercials. Get a diverse list of plant-based foods that they don't react to. Have them grind that up. Have them take a teaspoon of flax, psyllium, if they don't have small intestinal bacterial overgrowth issues. Take that in. Now they're going to get microbiome diversity. They're turning on their Treg cells. They're modulating their autoimmunity. That's a great supplement right there, those two things. Out of the health food store, cheap, right? Major impacts on their autoimmunity. So we know that these things are important. Treg function, we talked about it a little bit earlier, but the key things that have been shown to impact Treg functions nutritionally, vitamin D, vitamin A, glutathione are key things. Opioids, so exercise. Now here's the key thing with them with exercise, with autoimmunity. If you give them too much exercise, they get worse. So we have them exercise to get an opioid response, to get that feeling of high. So the longer someone exercises, the more free radicals they make. But people that have autoimmunity, if they work out for long periods of time, they end up crashing. So one of the things that we want to make sure we do with them is have them work out, get an opioid response, but not for a long period of time. So I have my patients use an app called 7-Minute Workout. And it's not in lieu of all their other exercises, but when they wake up, I have them go to the app, or we can go to a web page. The web page is free. They click it on, and it clicks on, and they go, do push-ups for 30 seconds. And it goes click, 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 and then do sitting squats for 30 seconds. And they do as many as they can. But when they do as many as they can in a short period of time, and that means you can do it for anyone's fitness level. Some will do 30 push-ups, some will do 3 push-ups. But the person that did 3 push-ups is still struggling because that was their best, right? So they'll get an opioid response because they're trying to do as many as they can in that 30 seconds to their fitness level. And you can easily have someone do that in the morning with 7 minutes, and now you get their Treg function. So picture this. You have an autoimmune patient. You get their list of supplements. You have a thyroid patient come in. You find their supplements. You find potential triggers. You get them on a gluten-free diet, right? Maybe you find what foods they're sensitive to. You have them wake up every morning, just do a 7-minute workout. Just first thing they do, just do a 7-minute workout. They want to work out later, that's fine, but just get that opioid response without overtraining. Then they go and take a Vitamix, blend a whole diverse list of plant foods. Then take a teaspoon of psyllium and flax, mix that up together, drink that, turn on their Treg cells, improve their microbiome diversity, improve their tolerance. Easy. Right? Now, if they want any exotic, more expensive supplements to it, they can, but that does a lot. Make sense? Okay. So those are some of the key things we do. So this is just a summary of the things that we look at for tolerance. Digestive enzymes break down the protein, short-chain fatty acid, probiotics, again, A and D, they go through different areas. I need to go all that, but I don't get to all that. Those are all critical. So I don't have time to give you all the things we do for Hashimoto's, but I just want to give you some of the most important ones. So our approach to hypothyroid, before I come to chemicals, our approach to hypothyroidism is first look to see if they have an autoimmune response by checking antibodies. If they have antibodies, we kind of shift our approach to thinking, do we need to really supplement their thyroid? Are they really deficient for something the thyroid needs? Or is there a mechanism destroying their thyroid? So with most people that have ongoing thyroid symptoms and high TSH, they have Hashimoto's. Then our question is, well, how do we calm down the expression of their autoimmune disease? It's not curable, but how do we have them have more good days and bad days? So then we try to look at supplements that could be triggers, we remove those, foods that could be triggers, and then we start with food. And with food, we try to improve their dietary tolerance by the strategies we discussed. Does that make sense? So I would rather have my thyroid patient take a diverse Vitamix food drink of different plant chemicals and some flax and psyllium than taking a cool, fancy thyroid glandular that's made from magic out of New Zealand with, someone blessing it. That you hear about. I don't really care about those types of things. I just want to try to improve their tolerance. If we can improve their tolerance, we can usually improve their function. Now, what about chemicals? Well, bisphenol A and tridothyronine have some similarity. Okay? Bisphenol A being in plastics. So one of the most common chemical triggers we're seeing with Hashimoto's patients is BPA. Now, and by the way, BPA, as you guys know, is without question a xenoestrogen, has impacts on the immune system. There was congressional and Senate hearings done with scientists to determine if BPA was safe. You know what their conclusions were? It's not safe, it's a xenoestrogen, but we still have it. And now we have BPA substitutes. What about BPA substitutes? They're worse. So they're finding that these BPA substitutes, like BPS, are actually worse. They're more estrogenic, but people go BPA free and they think they're getting something better, but you're not. Okay. So this is a paper I published in the journal Autoimmunity on BPA pathogenesis, and I reviewed all the literature and I put a summary diagram of what happens, what are the known pathways for autoimmune reactions with BPA. And there really is no human study done on BPA until we've done some. We're getting ready to publish. But BPA is very, very serious concern for many autoimmune diseases and especially thyroid. Okay? And I'll show you what I mean by that in a second. So first of all, where do you get your BPA exposure? Well, you get your BPA exposure so plastic bottles for sure. And the more heated the plastic bottle is, so we did this in-house thing just for fun. We didn't publish or anything. We took bottles of BPA, plastic bottles, 1 liter bottles of BPA. I mean, not BPA, plastic bottles that have BPA as a component. We put water in one, vinegar in another, and Mountain Dew. Baseline, and then after a month, what happens? The more acidic the compound is, and by the way, Mountain Dew is more acidic than vinegar, it's filled with sugar, the more BPA you release. Now, if you heat BPA, you release it. So picture a Mountain Dew stuck in the sun, stuck at a grocery store. Someone goes, that could be a high level of BPA. If you take food in a plastic dish and heat it, you're going to release BPA. If you drink coffee through a coffee lid, you're going to release BPA. If you drink coffee, take off the lid. Spill it on yourself. It doesn't matter. Don't drink through the lid. You're actually releasing it. Okay? Those are concerns. The most common exposure, you know what it is? Someone published this actually. Sales receipts. The ink on sales receipts are BPA. So what they're saying is people get sales receipts, they put it in their pocket, and it gets over all their money. And as they handle money all day, they get BPA exposures. Okay, so now picture this. You have a person who wakes up in the morning, they heat up their breakfast in a plastic dish. They then go to Starbucks, have their, or whatever, latte, tea, soy or whatever, or almond milk, and they drink it through the lid, glug, 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 right? Go and get their sales receipts, look at those all day, get all that BPA, and they're going, wow, I don't know why I'm sick, I eat great. Well, maybe there's a chemical component to this. Maybe there's some chemical issues there. Now, we did a study where we took chemicals and we bound it to albumin, and we wanted to see if that becomes a new target site for autoimmune disease. And we published it in the Journal of Applied Toxicology. Okay? So we took aflatoxin, formaldehyde, isocyanate, shimalic acid, benzenes, bisphenol A, tetrabromobisphenol A, tetrachlorine, mercury, mixed heavy metals, parabens, and parathyroids. And we mixed those and bound them with albumin. We then did negative ELISA testing to make sure it was bound with that protein. And we wanted to see in what % of the population that these chemicals existed in. So if you get the paper off Medline. But if you look at the paper, it was between 10 to 12% of the population have antibodies to chemicals bound to albumin. Here's what happens. When someone drinks, let's say, a solution of BPA, not all of it shows up in the urine because a lot of it is binding to your own protein. So the potential, this is a new model for autoimmunity. So if the chemical binds to your own protein, you can then make an antibody against it, and that's what we measured. Because you can't make an antibody against a chemical because you need a protein. So do chemicals bind to proteins and make new antigens? This is what we're looking at. Does BPA bind to a protein like albumin and then become a new epitope, new antigen for autoimmune triggers? So our first part was to publish, yeah, this does happen, and it happens in a pretty large percentage of the population. Then what we've done, and this is what we're publishing right now, we've taken those people that have reacted, and we're seeing, is there a correlation with things like TPO antibody and myelin basic protein? So we did it with myelin basic protein. P-value is less than 0.001. We had R values of 0.9, almost 1-to-1. So we know that some of these chemicals are very reactive, and I can tell you right now, thyroid is a concern. So as far as chemicals go that we're most concerned about right now with some preliminary evidence, we were really freaked out about latex, and we're really freaked out about BPA for thyroid patients because of potential immunological triggers. Okay, so those are our approaches to Hashimoto.